So I'm Mikey. I'm one of the R3s in the EM program. So we're going to talk about the COVID theme of the year. So today we're going to talk about COVID and anticoagulation. I apologize in advance for how quickly I'll go through the beginning, and I also apologize for all of the memes. I put them in at 2 in the morning last night. How do we decide on an anticoagulation regimen for patients with COVID-19? So obviously I did what everybody does. I went on UpToDate, and this is the algorithm that currently exists on UpToDate for deciding on anticoagulation in COVID patients. And the majority of it, I know it's very small, but the majority of it is very intuitive. So you essentially ask first, does the patient actually have a venous thromboembolism? In which case, then obviously you're going to put them on some kind of anticoagulation. And then within that, you decide whether the patient is stable or unstable. And then that's how you decide about lytics versus regular anticoagulation. If they're not, if they don't have any VTE, then the next question is obviously, are they already anticoagulated? In which case, if they are, you just continue the anticoagulation. So none of this is new and none of this is particularly surprising. What becomes more complicated is when you go down the arm of patient is not already anticoagulated, they don't have a venous thromboembolism, and they're going to be admitted to hospital. So then we're saying that we're around here, and then also they bring in level of care and how severe is the illness. So if this is a regular inpatient who is not critically ill, then you're going to put them on thromboprophylaxis to hospital. But the real question area becomes patients who are critically ill in the ICU, then anticoagulation is appropriate, but what they write is the level of anticoagulation remains to be seen. So whether we're giving a therapeutic or prophylactic dose. So let's talk about what we know. I'm going to go through this fairly quickly because in the interest of time and because most people already know this stuff. So what do we know about COVID? It's an RNA virus. It's in the RNA virus family, probably started with some kind of zoonotic source in China. It has a very wide range of disease severity. When I was last looking these stats up, so these are actually from last week, but we were at 69 million cases worldwide with over 1.5 million deaths. And Canada, we're not doing as well as we would have liked. We're over 430,000 cases, and we were almost at 13,000 deaths last week. So we've definitely crossed that milestone now. This is just a basic review of the pathophysiology, but essentially COVID behaves as any other virus and uses the cell's own mechanism and receptors to get access into the cell and then use the cell's ribosomal and mitochondrial mechanisms to self-replicate and then self-propagate as well. And this is mediated by the ACE2 receptor. This is a slide I found as well that talks about more of the pathophysiology of the disease progression. But what I like about this slide is that you can really see how there's many different areas of the body that can become affected. So you obviously have the lung, which leads to pneumonia. This can lead to acute renal injury. The ACE2 receptor can also play a role in cardiac dysfunction. And we also bring in the aspect of cytokine storm. I think most people have seen this slide by now. This is from EM Crit, and actually, when Emlyn was presenting on steroid use about a month and a half ago, she used the same slide. What I like about it is essentially it divides the COVID disease into the viral phase and the inflammatory phase. And this just brings into the idea that initially you're dealing with a regular virus almost that can cause a viral response, but eventually we get this very large inflammatory response, which involves the cytokine storm. And this leads us to believe that depending on where you are in the disease, you can have different application of different treatments, such as steroids and antibody-mediated treatments as well. I wanted to focus on the aspect of hypercoagulability in COVID. So this has been fairly well documented, and it seems that COVID is causing either macrovascular or microvascular thrombotic events. And the pathogenesis of this is not very well understood, but it's clear that it's acting on different aspects of Virchow's triad, which we all learn in medical school, and then we try to never think of ever again. So firstly, the overall inflammation of the disease state leads to a state of hypercoagulability. there is also the idea that because you're feeling weaker because of the disease, you're moving less, and this promotes stasis. And then there's also many theories that COVID itself can be involved in endothelial damage directly, and causes direct inflammation and injury to the endothelium, and this can further propagate the hypercoagulability. This has led to the idea of there being something called a COVID-19 associated coagulopathy, which is distinct but along the same spectrum as DIC. And obviously, when we see COVID patients, we also see a lot of coagulation abnormalities. The one that we'll focus a lot on is the elevated D-dimer, which has been noted to be a prognostic factor in these patients. This is just going again into Virchow's triad. And then just a basic review of physiology as well, and you'll understand afterwards why I'm actually bringing this up. But essentially, why do we actually care about the hypercoagulability? It's because it can actually have an effect on our level of hypoxemia in these patients. So we all know that the AA gradient is the difference between our alveolar and our arterial partial pressures of oxygen. And essentially, all I wanted to really highlight with this slide is that your arterial partial pressure of oxygen is related to the AA gradient, which can be dependent on the idea of VQ mismatch. So if we go back to VQ mismatch in a normal alveolus, you have blood coming in with carbon dioxide, it gets oxygenated, it leaves with oxygen. When you have something like a blood clot, you're essentially chopping off one of these arms, and you're thereby increasing your alveolar dead space. This means that more blood has to go to the same area, has to go to a smaller area rather, of oxygen rich alveolus, leading to the idea that you're going to have less overall oxygen in your blood. And this is why VQ mismatch can lead to a decreased PaO2. So when you think about that, it makes sense that anticoagulation would help to correct a microvascular VQ mismatching in COVID patients, right? That's what we're going to talk about. So my PICO was basically specifically in critically ill ICU patients with COVID, does therapeutic dose anticoagulation in the absence of venous thromboembolism, when compared to traditional prophylactic dose anticoagulation, does that offer an improvement for inpatient morbidity and mortality? So if I really break that down, so the population we're looking at is really critically ill COVID patients who do not have venous thromboembolism. So if you think about the arm of the up-to-date algorithm, we're really focusing in on that area I had circled. The intervention is giving therapeutic dose anticoagulation versus a control of prophylactic dose anticoagulation. And the outcome that I was hoping to really get an idea of would obviously be inpatient morbidity and mortality. So we're going to talk about 3 studies. The first 2 we're going to talk about briefly because they're older, and we're going to talk about the third one, which is the new one, and that's really the one that we're going to go into depth into. So this is a study by Tang et al., which was first published in March, which was basically, this was a retrospective observational study where they actually looked at about 450 patients in a suburb of Shanghai, China. And this was very early on in COVID. So this was January to February 2020. And they were basically looking at the use of low molecular weight or unfractionated heparin for 4 days or more in one group versus non-users in the other group. Importantly, here they were actually looking at prophylactic dose. So I haven't been able to, they weren't able to get into yet with the therapeutic dose versus prophylactic. They were initially looking at prophylaxis versus no anticoagulation at all. What was interesting is that they were able to stratify their results and the risk of coagulopathy according to an SIC score or the D-dimer level. The SIC score is it's a sepsis-induced coagulopathy score, and they were looking at 28-day mortality. So I included, this is the actual SIC scoring, and essentially you can see that it takes into account platelet count, their INR, and also the SOFA score, which is our what we use to give a marker of the severity of sepsis. So they were really trying to stratify things according to disease severity. This is how they broke down the patients. It's not particularly important for us because we'll go into the other one in more detail. But you can see that they really, firstly, they took out all of their they considered mild to moderate COVID patients, and they really focused in on severe COVID patients, and they divided those into patients who had gotten heparin and those who had not. And this was the mortality. In terms of the results, what they actually found was that there was no difference in 28-day mortality overall between heparin users and non-users. However, when you stratified the users according to their SIC score and their D-dimer, you found that the higher the SIC score and the higher the D-dimer level, you could see that anticoagulation was associated with a better prognosis. So, which makes sense, which is essentially them saying that anticoagulation was associated with a better prognosis in severe illness with evidence of coagulopathy. And this is their raw data. And as you can see, so the blue is heparin users and red is non-users, and this is their mortality. You can see that it's more or less the same, except on the extremes. So this is the area where the patients had high SIC scores, and this is the area where patients had high D-dimer scores. And you can obviously see a difference in mortality there. And that, like we said, it makes sense. So the second study I wanted to mention is this study by, I'm not going to be able to say the name, so it's also not so new when we're talking about COVID literature, although everything is new. And here, this was interesting. This was another retrospective observational study. It was about 2,800 patients in New York. And here they were actually looking at therapeutic dose anticoagulation versus non-therapeutic dose, or no anticoagulation at all. And they adjusted things for a lot of factors. They basically adjusted it for everything. And they also looked at the anticoagulation treatment duration, and they also factored in whether or not the patient was intubated. And they looked overall at in-hospital mortality and survival. So they divided their results firstly into all patients and then into ventilated patients. So when you look at all patients, overall, you can see that there's not too much of a difference between in-hospital mortality. There is a bit of a difference maybe in median survival, 21 days versus 14 days, but they did also mention that patients were more likely to require invasive mechanical ventilation if they were on treatment dose anticoagulation. So this is about 30% versus 8%, but we'll talk about that in a second. It becomes more interesting. So you can see that the treatment group, their in-hospital mortality for ventilated patients was about 29%, whereas in the prophylactic group was closer to 63%. And obviously you see a large increase in survival as well, 21 days versus 9 days. They also noted that the longer the duration of the anticoagulation treatment, it was associated with a reduced risk of mortality with the hazard ratio of about 0.86 per day. And this is their raw data. So this is for all patients in terms of survival, and this is for ventilated patients. The red is therapeutic anticoagulation. The blue is non-therapeutic. So you can see that there is still a gap even for all patients, but it really becomes quite large for the ventilated patients. Yeah, so that more or less, it's starting to go along with the idea that maybe there is a place for therapeutic dose anticoagulation, and this could actually possibly improve survival and reduce mortality. That said, the study had a lot of limitations. It was an observational study. There was no clear indication written for the actual use of the anticoagulation. And unlike the first study we looked at, there was no stratification according to illness severity. There was also probably a large element of indication bias. And as I mentioned, they made a note that patients who received therapeutic dose anticoagulation were more likely to require ventilation. But if you think about that, that doesn't necessarily make sense. And what makes more sense, and they acknowledged this as well, was likely that the patients who were receiving therapeutic dose anticoagulation were likely sicker in the first place, which is why you were kind of throwing the kitchen sink at them to begin with, and therefore they were more likely to require ventilation. So I don't think there is a cause and effect that can necessarily be traced there. So we'll talk about the third study, which is the main one that I wanted to focus on. It's called, I don't know, I've been calling it the HESA COVID for the last 2 weeks, and then I decided last night that I'm going to call it the HESA COVID because it makes more sense. So the HESA COVID trial Some of you might have seen this already. It was first published in September of this year online, and now it was just released in Thrombosis about 2 weeks ago. So that's why it's kind of become more of a known thing recently. So it is still fairly up and coming. So this is a randomized controlled open label single center phase 2 study. It took place in Brazil, and essentially they focused in on 20 mechanically ventilated patients from April to July of this year. Their intervention was therapeutic dose enoxaparin. They did talk about the possibility of using unfractionated heparin as well, but they didn't need to. And their control was against a standard dose thromboprophylaxis in their control group. In terms of outcomes, so what was interesting is their main outcome was actually looking at gas exchange. So they were looking at the PaO2 over FiO2 ratio. And now you say, that's why, Mike, you spent so much time on that weird physiology stuff at the beginning. So they were looking really at gas exchange, and they looked at this as a change over time at 0, 7, and 14 days. And other outcomes that they looked for were the time it took to get liberation from mechanical ventilation. And then they also looked at, in association with that, ventilator-free days. They also looked at variation in D-dimer levels between groups. And then obviously they also looked at 28-day all-cause and in-hospital mortality, and also the ICU-free days within those 28 days. With regards to their method, so fairly well done. They were able to do a blocked randomization. Essentially, patients who were enrolled in the study, it was drawn out of an envelope who would be in which group. So in the treatment group, they received subcutaneous enoxaparin with the dose being adjusted for age and creatinine clearance. There was this idea that they were going to give unfractionated heparin if needed according to the renal function, but in the end, they didn't need to do that for anyone in the treatment group. They maintained the anticoagulation for up to 14 days, and they held it if the patient was bleeding. And then they gave standard doses for prophylaxis. The PaO2 over FiO2 was blindly calculated. These were ICU patients. They were getting daily ABGs. They just used the PaO2 values off of those routine ABGs on the 0, 7, and 14 days and looked at their oxygen requirement at that time. With regards to ventilator liberation, they classified this as the patient having spontaneous ventilation for 72 hours minimum, and that's what they considered ventilator liberation. And they also calculated the TIMI bleeding criteria in order to give a safety outcome of the anticoagulation as well. So just a review a little bit for those of you, I'm sure most of you know, so for the PaO2 over FiO2 ratio, this is actually the same ratio that we use to calculate ARDS, the severity of a patient in ARDS. So we classify mild disease as having a PaO2 over FiO2 of 200 to 300 with this associated mortality, and severe is with a ratio of less than 100, which leads to a mortality of about 45%. So with regards to their inclusion criteria, so these are their inclusion criteria. I put it there for your interest. There's nothing particularly special about the inclusion criteria, except that they insisted that the patients have severe disease requiring mechanical ventilation, and that there was no evidence of increased bleeding times at baseline. So they did want patients with a slightly elevated D-dimer, but they wanted a more or less normal INR and normal platelet values. Their exclusion criteria, so they excluded very elderly patients and patients with severe kidney dysfunction. They also didn't include patients who were in severe shock with a significant pressor requirement. They also excluded a lot of advanced diseases. So we talked about kidney. There was also liver, severe heart failure, severe COPD, dementia, etc. No pregnant patients, and no patients who were considered surgical or trauma patients. And obviously, they didn't include any patients who had other indications for getting anticoagulation, such as PE or ACS. So this is their overall breakdown in the end. So they had 27 patients in total who were assessed for eligibility. 7 of them were excluded. And then, so when they did the randomization, there were 20 patients who were randomized, 10 to each group. The 10 therapeutic ones all received enoxaparin. Within the prophylactic group, 5 received low molecular weight heparin and 5 received unfractionated heparin. And all 10 in each group were followed through. There were none lost to follow-up. So let's talk about the results. So for the PaO2 over FiO2 ratio, which was their main outcome, if we look at the therapeutic group, you can see that at baseline, they had a ratio of 163, which was comparable to the other group. And then at 7 days, this increased to 209. At 14 days, it was 261. And the progression was found to be a significant difference with a p-value less than 1%. In the prophylactic group, you can see that while at the beginning they start out kind of similar, there isn't the same progression. So we go 184, 168, 195. And this was shown to not be a significant difference. Of note, there was one patient in the prophylactic group who died before day 14. So they used the ABG on day 12, which was the day he died on, as his last value to help calculate the ratio. And this is showing the same information as a graph. So this is the prophylactic group. Our ratio doesn't really seem to change with the days, whereas you can see that there is a nice progression with the therapeutic group. They also looked at they found that dose enoxaparin was statistically associated with an increase in ventilator-free days. So the red group is the therapeutic group, the blue group is the prophylactic group, and you can see that as you go through the days, you get more and more successful liberation from the ventilator, and they actually calculated a hazard ratio of 4.0, which is quite impressive. But again, 10 patients per group. They also looked at the D-dimer elevation. So as we mentioned before, D-dimer is a good prognostic marker for these patients, and it was measured at baseline and at 3 to 4 days. And you can see that in the therapeutic group, the D-dimer level actually goes down quite nicely, whereas in the prophylactic group, it goes up. So that's also very interesting. It's not necessarily telling you that these patients had a better prognosis, but we can possibly infer that as well, which goes along with the other findings that they were finding. With regards to the other secondary outcomes, so unfortunately, they didn't find that there was any difference in all-cause 28-day mortality or in in-hospital mortality, and there was no significant difference in ICU-free days. With their safety outcomes, essentially there was no major bleeding in either group. There was a bit of what they considered minor bleeding, like hematuria and bleeding from a PICC line site. And then there was some bleeding requiring medical attention. That's what they called it. 4 in the therapeutic group and 2 in the prophylactic group. And that was basically just associated with a drop in the hemoglobin, but none of these patients ever became hemodynamically stable, and it was easily managed in the ICU. And the deaths of the 2 patients in the therapeutic group at the end of the 28 days, these were not associated with bleeding, they were associated with infection. This is a summary of the results. What I really just wanted to highlight here, so this is the p-value when we're actually looking at the progression of the PaO2 over FiO2 ratios in the therapeutic group. What I also wanted to highlight, though, is that when you actually compare the 14-day ratio between groups, so this is the 261 versus the 195, there's actually no significant difference. So while you're showing that there is a significant difference in the progression within the therapeutic group, you're not necessarily showing that at the end of the 14 days, there was a significant difference between the ratio of the therapeutic group and the prophylactic group. So yes, there was a progression, but it didn't necessarily show a difference compared to prophylaxis. So take that as you will. With regards to the internal validity, so was the assignment of the patients randomized? Yes. Were the groups similar at the start of the trial? Yes, they had very similar baseline characteristics. I'll show you on the next slide. And what was nice is that they also were able to stratify according to disease severity, and it was similar with regards to disease severity and D-dimer levels. Aside from the allocated treatment, were groups treated equally? Yes, they were all mechanically ventilated on the same lung protective strategy. They had the same ventilator liberation protocol, and they had similar requirements for proning and pressor use. They also got the same antibiotics and steroids, and neither group had access to NO or ECMO. So this is the demographic information. So you can see everything was more or less similar. There was no significant difference. I've highlighted the proning because I think that's important. Both groups were similarly proned. They both had similar numbers for norepi use and for corticosteroids. Their D-dimers were more or less similar at baseline, and these are the scores they used to calculate disease severity, which again were similar between the groups. Were all the patients in the trial accounted for? Yes, like we mentioned, none were lost to follow-up. Were they analyzed in the groups to which they were randomized? Yes, and were measures objective? So patients were blinded, obviously, because they were being mechanically ventilated. Clinicians were not, but at the same time, these were objective endpoints, so it didn't necessarily matter. The only thing that I noted is that they didn't write any indications for the discharge from ICU, but because they didn't actually find a difference in ICU free days between groups, it didn't actually matter. The limitations, very small sample size. We're talking only 20 patients, so obviously their power is very reduced as associated with a reduced external validity and therefore not a lot of generalizability. There is potential for very high applicability here, though, just because it's very easy to do the same kind of study because every hospital has access to doing either prophylactic or therapeutic anticoagulation. The only real limitation that I noticed that they kind of skimmed over, they didn't actively investigate for any VTEs prior to randomizing the group. So even despite not actively looking, in the end, they did find that 2 of the therapeutic patients had DVTs and 1 of the prophylactic patients had DVTs and 1 had a PE. So is this because were we actually seeing an improvement because we're doing something when they don't have a VTE, or is it because that there were more patients in the therapeutic group who did have underlying thromboemboli and we were just treating those, and that's actually why we were seeing the improvement? Discussion. So therapeutic enoxaparin was found to improve the gas exchange over time. It was associated with decreasing D-dimer levels, and it was associated with a higher ratio of successful liberation from mechanical ventilation. There was no apparent increase in the bleeding risk. I know Audrey's gonna get mad at me in a second. So what should we do as doctors? Because at the end of the day, that's really what we care about. So unfortunately, I can't give you an answer, and that's why UpToDate couldn't give me an answer either. It's very hospital and ICU dependent. So the Lakeshore is doing therapeutic dose for all of their ICU patients. I just spoke to some of the staff at the Jewish yesterday. They're still doing prophylactic dose. There's no right answer and there's no wrong one. The important things to know is that in general, you follow the traditional guidelines for all patients unless they're critically ill. And then if they're critically ill, you discuss with the ICU attending and you see what they prefer. The other important thing to know is that if you decide to put a patient on therapeutic anticoagulation, if they have severe disease, it's not incorrect so long as they have a low risk of adverse events, namely bleeding. So if you decide to do that and they change it afterwards, that's okay. And the guidelines are going to continue to change. This is just the same slide again. Next steps, we're going to do larger sample size. There's going to be a vaccine, hopefully that's great. And next study, they should also rule out thromboemboli prior. And that's the end. Resources, any questions? Sorry, I know that was really fast.